Pulmonary hypertension in patients with AIDS. Up to 1998, about 88 cases had been reported. The mechanism is still indeterminate. Although confounding factors may be present, it is still widely believed that the HIV itself is the cause of the pulmonary hypertension. Currently, the most plausible theory implies that an indirect mechanism, or the so-called bystander effect, is responsible. A study on monkeys has shown that an arteriopathy can be observed similar to that described in the primary pulmonary hypertension, so-called plexogenic arteriopathy. Investigators were not able to demonstrate the presence of any virus or viral DNA in the pulmonary endothelial cells. Therefore, the terminology of indirect bystander effect. Alveolar macrophages are frequently infected with the HIV virus, and they can release lymphokines, which enhance leukocyte adherence to the endothelium and promotes endothelial proliferation. Some authors have described the HIV TAT regulatory gene protein, which is one of 6 genes important for viral gene expression and replication. It leads to the release of epidermal growth factor, transforming growth factor B and platelet-derived growth factor, and these cytokines are thought to induce nitric oxide synthase, which leads to increased vessel tone and proliferation of the endothelium. Some authors have described the GP120 HIV type 1 envelope glycoprotein that stimulates the production of endothelin-1. Endothelin-1 is known to be a very potent vasoconstrictor, and this may precede the structural changes in the pulmonary arterial tree. And also tissue necrosis factor alpha in a concentration-dependent manner can also be the result of the GP120. Using PCR, these authors demonstrated a chronically increased expression of endothelin-1 in HIV-infected patients. It must be remembered that there can be secondary causes of pulmonary hypertension in patients with HIV, so-called AIDS syndrome. The intravenous drug abusers can inject themselves with products that have talc, and talc granulomas has been described in the pulmonary arteries and can lead to increased pulmonary vascular resistance. Portal hypertension and chronic hepatitis and cirrhosis is another mechanism for secondary cause and has been described in 13 of the 88 patients reported in the literature, that is 15%. Finally, coagulation disorders appear to account for about 3% of the cases reported up to 1998. This is a 48-year-old man known to have AIDS, presented with shortness of breath. Surprisingly, no parenchymal changes were noted in the chest radiographic examination. However, there were signs of precapillary pulmonary hypertension, as demonstrated in these two views. Note the enlarged pulmonary trunk and centrally enlarged pulmonary arteries with the paucity of the peripheral pulmonary vasculature. This 28-year-old woman was admitted first at the University of Miami School of Medicine, and subsequently she had her workup at Mount Sinai Medical Center in Miami Beach. There was no significant past medical history or risk factor, and she complained of progressive dyspnea for 5 to 6 years. On frontal and lateral chest rentgenograms, note marked pancardiomegaly. The right atrial border is prominent. There is evidence of an enlarged right ventricle, a prominent pulmonary artery segment, and also a prominent left heart border. The aortic knob is small. The central pulmonary arteries are slightly enlarged, and peripheral oligemia was observed. The ventilatory scan seen on the top left only revealed the focal air trapping in topography of the left lower lobe. The perfusion scan seen on the bottom right showed a linear non-segmental defect corresponding to the left major fissure. we could not see any segmental lobar defects in the perfusion scan. But the interesting finding was also the presence of uptake at the level of the brain and of the level of the kidneys. This patient had arterial hypoxemia, and the scintigraphic findings correlate with the presence of a right to left shunt, which proved to be at the atrial level. This is a CT pulmonary angiogram showing a prominent superior vena cava and a very large pulmonary trunk and central pulmonary arteries. Note that the pulmonary trunk is twice the size of the aorta. Coronal reconstruction reveals the centrally prominent pulmonary arteries. Note the paucity of peripheral pulmonary vasculature and the absence of filling defects. Note also the markedly enlarged right heart chambers and reflux into a very large inferior vena cava and into the hepatic veins. Coronal and sagittal reconstruction CT angiograms reveal markedly enlarged right heart chambers. It was the right atrium and right ventricle that caused the cardiomegaly, and they simulated enlargement of the left heart chambers. Also note the markedly enlarged pulmonary trunk and the pathognomonic sign of a right to left shunt. This is derived from the fact that the left and right heart chambers opacify simultaneously from the communication between the right atrium and the left atrium. Axial image of a CT pulmonary angiogram shows the markedly enlarged right atrium, which bulges the interatrial septum, the relatively small left atrium, simultaneous opacification of both chambers indicative of a right to left shunt at the atrial level, and a markedly enlarged right ventricle with a relatively small left ventricle. Axial images of the upper abdomen reveal generalized hepatic enlargement and contrast material in hepatic veins and a markedly dilated inferior vena cava. This was the result of the severe pulmonary hypertension, the tricuspid insufficiency, and the hypertension involving the right heart chamber. Note the dilated hepatic veins and inferior vena cava due to right heart failure. Echocardiographic examination revealed a markedly enlarged right ventricle and right atrium. The intraatrial septum and the interventricular septum protruded towards the left heart chambers. There was evidence of severe pulmonary hypertension with a pulmonary arterial systolic pressure of 85 millimeters of mercury. The pulmonary and tricuspid valves were incompetent, and a right to left shunt was present at the atrial level, and this was believed to be due to a patent foramen. A bubble study, which is performed by shaking saline and injecting intravenously, revealed echogenicity in the left heart chambers due to the passage of the bubbles from the right atrium to the left atrium. The history of this patient was quite interesting because although the diagnosis of pulmonary hypertension was obtained, the patient was considered to be a candidate for lung transplantation. In the workup of the patient, it was found that the patient was HIV positive, so the lung transplantation was canceled.